So let me begin where we left off yesterday. Now this picture shows you some important vertebral levels that I would like you to pay attention to. So for example, if you take the jugular notch and you take a line across it, it hits the intervertebral disc between T2 and T3. The sternal angle, or what is called the manubriosternal joint, the disc, intervertebral disc between T4 and T5. The xiphisternal joint hits the 9th thoracic vertebra, and then the others which we saw, for example, the aorta passes behind the diaphragm at the level of T12. So some of these which are given here and in your notes are important for you to know. Now let's look at the musculature of the thoracic wall. There are 3 layers. The portion which lies outside the ribs, we will do with the upper limb, and you will do some of it with the abdomen. So those muscles, for example, the pectoralis major, serratus anterior, and so on, we are not going to do right now. The ones we are going to do are these two. So between the ribs, we have muscles which are called external, internal, and there's another one called innermost intercostal. And internal to the ribs are subcostals and transversus thoracis. The reason I have an asterisk next to the innermost intercostal, which is this one here, is actually this innermost intercostal, the subcostals and transversus thoracis are really all part of one layer. And it's kind of divided into 3 portions. So if I divide the 3 layers like this, and I was to show you something like this. So innermost intercostal is this middle layer which is present along the lateral side of the thoracic cage in the middle. The subcostals are present in the posterior part of the intercostal spaces, just in the posterior part. And the transversus thoracis is just present in the anterior portion of the intercostal spaces. So you do not see all of them everywhere. So it's kind of broken up into 3 layers. The actions, the external intercostals are inspiratory muscles. The internal, innermost, and transversus are expiratory muscles, especially when you have forced expiration. Subcostals are very weak, as you'll see when we look at the images. The main function is to prevent the intercostal spaces from being sucked in during respiration. We look at the blood supply and nerve supply of these muscles. The blood and nerve supply are the anterior and posterior intercostal blood vessels. This stands for intercostal and blood vessels, and by intercostal nerves. So let us look at these muscles first. So the first layer we are going to look at, the outermost layer of the intercostal muscles, is a muscle called external intercostal. The fibers run from the rib above to the rib below, and they run in an antero-inferior fashion. So you can see they're coming down like that. They're coming down like this, antero-inferior. And this external intercostal muscle is replaced anteriorly by a thin membrane, which is known as the anterior intercostal membrane. So that's called the anterior intercostal membrane. The internal intercostal and innermost intercostal run in the same direction, with the internal intercostal being intermediate and innermost being the deepest layer. They run in a direction which is postero-inferior. So they run this way. So postero-inferior, from the rib above to the rib below, in a postero-inferior direction. So here you can see an external intercostal. Second layer is internal intercostal, and the third layer is innermost intercostal, which, as I told you, the innermost intercostal layer is present in the middle this lateral part here of the thoracic cage. You don't see it posteriorly and you don't see it anteriorly because it's replaced by other muscles over here. This internal intercostal, when you take it all the way back, it begins muscular from the side of from the margin of the sternum, because here there is anterior intercostal membrane, so you want something more protective at the back. So the internal intercostal muscle begins from the lateral margins of the sternum. So it's muscular all the way from here. As you take it all the way back, at the posterior part, it's replaced by membrane, which you can see here. And that membrane is called posterior intercostal membrane. It's not all that important, but I'm mentioning this so that if you read about it, you know where that is present. The innermost intercostal, does not have any membrane because it's only present in the central region. Now, the nerves and blood vessels lie in a plane which is called the neurovascular plane, and that's between layer 2 and 3. So that means, and you can see it up here, so it's lying, this neurovascular plane is between the internal intercostal muscle here and the innermost intercostal muscle up here. Lying deep to the innermost intercostal, lying deep to it, is a fascia which is present, which you will see in another image, and that fascia is up here. So if I was to cover all this, so there'd be this fascia which is present here. That fascia is called endothoracic fascia. As the name signifies, you can see endo, inside the thoracic cage, endothoracic fascia, and that separates these muscles from the serous membrane inside, which is parietal pleura. And again, we will be looking at these in another subsequent image, but I wanted you to look at this right now. Now, we often call the 3rd to the 6th intercostal spaces typical intercostal spaces. The others are not called typical, only because the 3rd to the 6th spaces have a common general plan of arrangement. You will see that the arteries arise from a common stem, the nerves behave in a similar fashion, and so on. So the 3rd to the 6th are called typical intercostal spaces. Notice these blood vessels over here. So you can see, I want you to kind of pay attention right here to this arrangement of blood vessels. You can see this is the main neurovascular bundle. This is a bundle which is called collateral branches. We'll be discussing that. But what I want you to see up here is that the vein is the superiormost structure, the artery is intermediate, and the nerve is below. So this is called the van arrangement. You'll also see that in an intercostal space, which is up here, these 3 structures appear to lie in a little groove which is here, this little groove, because the rib, when you look at the rib is grooved at its inferior aspect. This groove here is called the costal groove. So this main neurovascular bundle lies in this costal groove, and in an intercostal space you can see that this main neurovascular bundle is lying along the upper part of the intercostal space. So this is the upper part of the intercostal space and this is the lower part. The main bundle lies in the upper portion of the intercostal space, and that's clinically important, which we'll talk about later. This is the other part of that innermost layer. Just remember I said that there was that innermost intercostal muscles which were kind of present here in this lateral portion, but posteriorly they are replaced by these very, very small muscles which span 2 spaces or may even span 3 spaces. These are known as subcostals. As you can see, they are very, very small, so they hardly have any action. And anteriorly, where again that innermost intercostal is deficient, anteriorly they are replaced by this muscle which is called transversus thoracis muscle. So it takes origin from the xiphoid process and the lower part of the body of the sternum and goes to the 3rd to the 6th costal cartilage. So you can see up here, so this is how it's going. So again, a small muscle but a bit bigger than the subcostals. So here this is showing you a dissection of the thoracic cage, and the front portion has been removed and you're looking at it from the posterior aspect. So notice up here, here is the transversus thoracis muscle, and more superficial to it is the internal intercostal, and between this, because this is the innermost layer, between internal intercostal and this transversus thoracis, you can see the neurovascular plane. And here anteriorly, these are blood vessels which are known as internal thoracic blood vessels. These are called internal thoracic blood vessels. We will be looking at these before, but I just want you to pay attention to this, seeing that this neurovascular plane is between layer number 2 and layer number 3. This is a horizontal section shown here, and if you look from here, notice the external intercostal coming all the way from the back, traveling up front, and then anteriorly it is replaced by the external intercostal membrane. So this part here is the external intercostal membrane. The internal intercostal muscle, because this is membranous here, so you want to strengthen it, the internal intercostal muscle begins from the lateral margin of the sternum, travels all the way back, the I stands for internal intercostal, and goes posteriorly, and there it is replaced by membrane, which you can see here. So this is the internal intercostal membrane, strengthened by muscle posterior to it. This is the innermost intercostal. IN stands for innermost. You can see this here. So if we were to kind of take this about the mid-level of the thoracic cage, then you will see that the innermost intercostal muscle, you can only see it's present along the lateral portion. Posteriorly, it is replaced here somewhere by subcostals, and anteriorly, it's replaced by the transversus thoracis muscle. The neurovascular plane is always between layers 2 and 3. So up here you can see the aorta. Also notice, I want you to notice the position of the aorta. If we take this as the midline up here, the aorta lies to the left of the midline. And notice here it gives off a branch which travels in, and you can see it's lying between layers 2 and 3. It comes all the way. By the time it comes up to here, this branch becomes a little small. It then anastomoses with a branch which is given off by these vessels which I was talking about, the internal thoracic. So here you can see anteriorly is the internal thoracic artery. It gives off a branch. So these two branches anastomose. So again, the neurovascular plane is always between layers 2 and 3. I also want you to pay attention up here at the nerves. So here you can see this is the sympathetic chain, spinal cord. This part here is the spinal cord, the spinal nerve coming out. Notice how the spinal nerve gives off this dorsal ramus. And then here, this part here is the ventral ramus. This part here is the ventral ramus. And we will see how it's actually these ventral rami which we call intercostal nerves. And we'll discuss this again. So notice how it comes again between layers 2 and 3, gives off cutaneous branches laterally, comes anteriorly, gives off cutaneous branches anteriorly, and then we'll see how it gives muscular branches to all these various muscles. Now sometimes ribs may be fractured and you get a condition called flail chest, and this happens when multiple ribs are fractured, and so it causes a paradoxical movement. Normally the chest moves out during inspiration and in during expiration, but this does exactly the opposite. So that's why it's called a paradoxical movement, and it impairs proper ventilation. It can be quite painful. So let's look at a video showing this. So notice how it's moving in during inspiration, out during expiration. So this is a flail chest. So the whole video goes on about that. So I just wanted to show you this. And obviously that needs to be treated. Now let's look at the vasculature of the thoracic wall, and we'll deal with arteries first. So as I said, the bundle lies in the costal groove with the van arrangement, which is vein, artery, nerve. Vein lying superiormost, artery, so when you think of it, it will be like this. This is superiormost and the nerve is inferiormost. We already talked about this yesterday. There were 11 posterior spaces and 9 anterior spaces because ribs 12 and 11 don't reach the sternum. So therefore, there'll be posterior intercostal arteries and you'll also have anterior intercostal arteries. And the two arteries will meet in the intercostal spaces. And that's because, as we look at this previous picture here, as I mentioned, this is the aorta. So this gives off a branch, but the branch cannot sustain itself right up to the front. So it's got to be supplemented by something coming from the front as well. So arteries which come from behind will be called posterior intercostal arteries. Arteries which come from the front are called anterior intercostal arteries, and they anastomose in these spaces. So where is the origin of the posterior intercostal arteries? In the first two spaces, that means space number one, first intercostal space and second intercostal space, the posterior intercostal arteries arise from a branch of the subclavian called costocervical trunk. As you can see, the name itself kind of tells you it has something to do with the intercostal spaces. Part of the artery goes into part of its branches go into the costal region, the first two intercostal spaces, and the rest goes into the neck. So in the first two spaces, the posterior intercostal arteries arise from a branch of the subclavian called the costocervical trunk. In the remaining spaces, that means third to the 11th space, the branches come off from the thoracic aorta, which is what I showed you in that slide a couple of slides back. So from third to 11th space, they arise from the thoracic aorta. And below the 12th rib, there is no space. The artery there is called the subcostal artery, and that also arises from the thoracic aorta. Now, anterior intercostal arteries, there are only 9 spaces, so we have to have anterior intercostal branches in 9 spaces. There are 2 arteries in each space, so there are 2 anterior intercostal arteries in each space. In the first 6 spaces, space number 1 to number 6, they arise from the internal thoracic artery, which I showed you again in that slide. And the internal thoracic also happens to be a branch of the subclavian. And the lower of the 3 anterior intercostal spaces, that means the 7th to the 9th space, they arise from the musculophrenic artery. The musculophrenic is actually a branch of the internal thoracic. So just to give you a preview, the internal thoracic travels like this, gives off anterior intercostal branches on, so let me do that again. So an internal thoracic artery of both sides gives off anterior intercostal arteries to the first 6 spaces, this one for the left side. And then this divides into musculophrenic and an artery which goes down, which is called superior epigastric, and this one is called musculophrenic. We will be looking at these pictures. So this, at the level of the 6th space, is where this internal thoracic artery divides. So therefore, the 7th to the 9th space will get supplied by musculophrenic because the internal thoracic is no longer present. And superior epigastric, of course, goes into the abdominal area, and that's where we'll see it. So you need to know which arteries are, where these arteries are arising from and what they are branches of. So let us look at these now. And okay, before we look at that, let's describe the internal thoracic. So it's a branch of the subclavian, as we just said. It gives off anterior intercostal arteries to the first 6 spaces. We will see that it also gives off perforating branches to the thoracic wall. So they perforate muscle and come to the anterior portion of the thoracic wall. You will see later when we do the cavity that it will give sternal branches, it will give branches to the pericardium. There's a gland there called the thymus. Then this artery divides into its 2 terminal branches. This is the one which gives branches to spaces 7 to 9. And we will also see that these intercostal spaces are supplemented, and this is important because it establishes anastomosis. It's supplemented on the lateral side by an artery called the axillary artery, which is actually the continuation of the subclavian artery. So the axillary artery supplies the lateral thoracic wall through its branches. So we'll be looking at all of this. So here let's look at this picture. So first let's take care of the anterior intercostal spaces. So here is the aorta. This is the subclavian artery. So again, I always want you to look at labels, so please make sure you look at the labels. So up here is the subclavian artery. It gives off this internal thoracic artery, and you can see the internal thoracic arteries on either side of the sternum. So they are not lying directly posterior to the sternum, so they won't get injured if the sternum is fractured, less likely to get injured. They lie lateral to the sternum. So up here you can see the anterior intercostal, the internal thoracic artery. And this internal thoracic artery is giving off anterior intercostal branches in the spaces, the first 6 spaces. This then divides at about the level of the 6th costal cartilage over here, or 6th space. It divides into musculophrenic and superior epigastric. So this one here is superior epigastric. This goes into the abdomen. The musculophrenic travels and gives branches into spaces 7th, 8th and 9th. So it gives branches in these 3 lower anterior intercostal spaces. Let's look at the posterior intercostal arteries. So this subclavian artery gives off this branch, which is the costocervical trunk. And the costocervical trunk in the first two spaces gives off the posterior intercostal arteries. So in the first 2 spaces, the posterior intercostal arteries come from the costocervical trunk. In the remaining spaces, remaining 9 posterior intercostal spaces, the branches come from the thoracic aorta. So here you can see this is the thoracic aorta. In this picture itself, I want you to kind of pay attention. Notice how the aorta begins anteriorly, very close to the sternum, but it kind of bends over like that, like an arch, and then goes posteriorly, where it's lying more to the left of the vertebral column. So therefore, the right posterior intercostal arteries are a bit longer than the left ones. So thoracic aorta on either side gives off posterior intercostal arteries. They are single to begin with, and then later you will see that they actually give off a little branch below, which is called the collateral branch. So they finally become 2 posterior intercostal arteries, so that these 2 can anastomose with the 2 anterior intercostal arteries which you see here. The anterior intercostal arteries which arise from the internal thoracic may arise first as a common stem and then divide into 2, or you may get 2 coming off straight away. So in each intercostal space, you'll therefore have 2 arteries. The main bundle lies at the inferior border of the rib, and the lower branch here is the collateral branch of this posterior intercostal artery. So they are anastomosing. And then on the lateral aspect, this subclavian artery, which goes into the upper limb, so this subclavian artery, as it crosses the outer border of the first rib, it gets into the upper limb, into the axilla. It's called the axillary artery. This axillary artery gives off many branches. One big branch which is present along the lateral aspect. So there's a big branch present along the lateral aspect. So if I draw the axillary like this and show you a big branch present along the lateral aspect, this is called the lateral thoracic artery. And this sends off branches which anastomose with these intercostal vessels. So you can see there's a very rich anastomosis going on over here. So let's look at the same thing if we take a section and we look at a typical intercostal space from the 3rd to the 6th. So here you can see this is the intercostal space. This is the costal groove which is present up here. You can even see the posterior intercostal membrane. Here is the aorta, more towards the left. So this is giving off the posterior intercostal artery on the right side. So it travels along in the costal groove lying between the vein above and the nerve below. as it comes further into the groove, it gives off a branch to the lower part of the intercostal space. This lower branch is called the collateral branch. The main artery continues to travel in the upper part of the space. The collateral branch travels along the lower part of the space, and you can see collateral branches. Here is the internal thoracic artery, giving off its two anterior intercostal arteries. So notice how these anterior intercostal arteries travel posteriorly and they anastomose with the main branch and the collateral branch. So each intercostal space therefore has the main branch lying along the superior part of the space and the smaller collateral branches lying along the inferior part of the space. And if I was to show you, here somewhere would be the lateral thoracic artery, which is a branch of the axillary. So this will come and anastomose over here. And this anastomosis becomes important if one artery is blocked. Notice that we also pay attention to how the veins are lying, pay attention to how the nerves are present, and because we'll be talking about them again. Now, if we were to take a section from the thoracic wall and go from skin right up to the lung, this is the order of structures we'll see. So skin is outermost, then there is subcutaneous fat. You'll see this muscle called serratus anterior, which is part of the upper limb muscle. And then we have the external intercostal muscle, internal intercostal muscle, innermost intercostal. Notice the neurovascular bundle between them. Then here is the this yellow layer is the endothoracic fascia, separating these structures from the parietal pleura. So this darkish blue is parietal pleura, which you see here. This is visceral pleura, and this is the lung. And in between the parietal and visceral pleura, this area here is the pleural cavity, which is filled with fluid. You may have a condition sometimes where the pleural cavity, the fluid in the pleural cavity increases, or there may be air in the pleural cavity, which we'll do when we do the pleura, and you need to remove the air or the fluid. So when you do that, you do what's called a pleural tap, or also called thoracocentesis. So you have to pass your needle through to remove the fluid or air. You have to worry about this bundle, this van bundle, because you don't want to injure it. So you never want to poke your needle along the upper part of the intercostal space, because you are more than likely to hit one of these structures. So it's best to pass your needle just above the upper border of the rib below in the space, or you go along the lower part of the space and you pass your needle here. And so this way you'll avoid hitting these collateral vessels and the nerve, and these are rather small. So when you go here, you will pass through skin, superficial fascia, external intercostal muscle, internal intercostal muscle, innermost intercostal. You'll pass through endothoracic fascia, you'll pass through parietal pleura, and then you'll be inside the pleural cavity. So this is the order of structures you will pass to enter the pleural cavity and withdraw the fluid. So again, looking at this image should give you a good idea of the structures you will pierce, why you want to go along the lower part of the space, or what is the superior border of the rib below, rather than the inferior border of the rib above, because you don't want to injure this main bundle. So here the posterior intercostal spaces, again just a review, you can see where the branches arise, and the anterior intercostal where the branches arise and what they are branches of. Now there is a condition which is known as coarctation of the aorta, which happens, and where this collateral circulation is set up. Collateral circulation means an anastomosis happens because of the arteries meeting up. Coarctation of the aorta is a condition which occurs at the site of ligamentum arteriosum. So what is this ligamentum arteriosum? In fetal life, this is the arch of the aorta. It gives off 3 branches. This one is called brachiocephalic. Don't worry too much if you don't remember these names. We'll be doing them later. This one is called left common carotid, and this one is called left subclavian. The brachiocephalic then further divides into right common carotid and right subclavian. And this subclavian is the one which you saw gave off the costocervical trunk, and from the subclavian you also have the internal thoracic, which you can see here. In fetal life, there's this artery, the pulmonary artery, which you can see here. This pulmonary artery is connected. So if I draw the pulmonary artery up here, this pulmonary artery in fetal life is connected by a branch, a duct, an arterial duct, which is called ductus arteriosus, because the lungs are not functioning. So the lungs are not functioning, so no oxygenation goes into the lungs. So blood from the pulmonary artery travels via ductus arteriosus and then comes down into the aorta. The blood in this region and going to the head and neck is more oxygenated. The blood coming down into the rest of the aorta is less oxygenated, and we won't go into that because that's a whole new chapter on fetal circulation. When the child is born, the child cries, the lungs begin to function. This thing closes up. This ductus arteriosus closes up and becomes what is called ligamentum arteriosum. There are various theories as to why coarctation occurs. One say that this ductal tissue probably goes in more than it should. So when it does this, it kind of narrows up the aorta. So the aorta becomes narrow like this, as is shown here. Another theory called the hemodynamic theory is that probably less blood supply was going, and this, because of less blood supply going to this area, the area becomes narrower. There are further other theories, but whatever the theory is, this coarctation or area of narrowing can occur after this ductus arteriosus. So it occurs somewhere here. So these 3 escape the narrowing. So this kind of coarctation is called post-ductal coarctation, and is the more common variety. You may have a condition where this actually may occur somewhere here. It can involve a huge segment. If it involves right from brachiocephalic all the way up, this very often is not compatible with life. Or it may be such that it only involves, it spares the brachiocephalic but maybe just involves the left subclavian. So whatever the case may be, a collateral circulation has to be set up, or if it involves, as I said, a whole segment like this, is not compatible with life. We'll discuss this post-ductal case where the coarctation is occurring after the subclavian has been given off, and let's see how the collateral circulation will be set up. So take a look at this picture. So I kind of want you to look at this picture. So here's the brachiocephalic. So on the right side, everything is normal. On the left side, the subclavian artery is, everything is normal when I say is, as far as the subclavian and the common carotid, right subclavian. Here's the left common carotid. Here is the left subclavian artery. And this left subclavian artery gives off, if you remember, it gives off the internal thoracic artery. So this part is all okay. But after the subclavian, notice here there's this coarctation. So the blood flow to the aorta then is less. So think about how the blood will flow. You can see this anastomosis being set up. So you have anterior intercostal vessels, you have the axillary artery and its lateral thoracic branches, and you have posterior intercostal arteries. So think about what would be the way blood would flow. And so I'll ask you a question on that. And usually, because of this great blood flow and blood flowing under pressure, very often you see notching of the rib because the rib gets slightly eroded. So here's where the rib is slightly notched in this portion. So rib notching is very typical of coarctation of the aorta. So So here's a question that I want you to think about. So think of your answer. So stop my video at this point and think of the answer. So think what would be the direction of blood flow. And I want you to pause, think of the answer, and I'm going to tell you the right answer. The right answer is from anterior intercostal to the posterior intercostal arteries and supplemented by the axillary artery. And here's why. So let's look at this. So the subclavian giving off the internal thoracic on both sides is normal. But when you come off, and in the first two spaces, costocervical trunk, that's normal. But when you come down to the thoracic aorta, because blood flow into the thoracic aorta is going to be less because there's this narrowing up here. So posterior intercostal arteries are going to get very little blood because less is flowing through the thoracic aorta. So the way blood actually goes into the thoracic aorta and can go down into the abdomen and further down is, and I'm showing you one side, so through the anterior intercostal arteries, by means of the internal thoracic, so directly from internal thoracic or from its musculophrenic branch, blood flows through the anterior intercostal arteries, goes posteriorly into the posterior intercostal arteries, supplemented by this axillary artery. So now blood flow is more going this way, it's going towards in a posterior direction. And then that blood flows into the thoracic aorta, and that blood flows down, and that's how the rest of the body can get its blood supply. Now normally blood flows in this direction and in this direction, so the flow is kind of well adjusted. But in this case, in coarctation, because there's greater flow and all of it is directed posteriorly like this, because of this greater flow, that's why there is this erosion and rib notching occurs. Now let's look at the venous drainage. Anteriorly, the venous drainage is very similar to the arteries. In other words, if the artery is coming off from the internal thoracic, the veins will go into the internal thoracic. If the artery was coming out from the musculophrenic, the veins will go drain first into musculophrenic and then go into the internal thoracic. And while we are here, I want to mention one thing. When we talk of arteries, we talk of arteries having branches. When we talk of veins, we say veins open into another vein, or another word we use is the veins drain into another vein. So I would say anterior intercostal veins drain either into the internal thoracic vein or musculophrenic vein, and then musculophrenic drains into the internal thoracic. Or I can say, if I ask you what are the tributaries, direct tributaries, another word we use for veins is tributaries. So what are the tributaries of the internal thoracic vein? You would say it is the anterior intercostal and musculophrenic, because this drains into this and this also drains into this. So those are the terms we use for arteries and veins. Posteriorly, it's a bit different. We have something known as the azygos system. This is on the posterior thoracic wall. On the right side, we have a vein which is called the azygos vein. And this vein we will see connects the two vena cava with each other. On the left side, instead of having one vein, we have two veins. One is called the hemiazygos and the other one is called accessory hemiazygos. These two, the hemi and accessory hemiazygos, at the level of the 8th thoracic vertebra, they cross over and join the azygos vein. So we'll be looking at this. So finally, everything goes into the azygos vein. So in the picture, in the slide, I want you to pay attention to the right posterior intercostal veins and the left posterior intercostal veins. You'll notice that the right posterior intercostal veins drain into the azygos vein. Most of them drain into the azygos because that's what's present on the right side. But some veins may go into the brachiocephalic vein. On the left side, the left posterior intercostal veins, they drain either into the hemi or accessory hemiazygos vein, or a few may go into the brachiocephalic vein. Finally, the blood from the hemi and accessory goes into the azygos vein. As I told you, at the level of the 8th thoracic vertebra, both these veins cross from left to the right side and drain into the azygos vein. So we will be looking at this. So here's a large picture which you can see. So this up here is the right brachiocephalic vein. This is the left brachiocephalic vein. Notice the two join together and form the superior vena cava. This here is the superior vena cava. I don't think it's been labeled. So this is the superior vena cava. This here is the inferior vena cava. And notice this vein up here, which is the azygos vein, joining the superior to the inferior vena cava. So this is the azygos. Notice this is present on the right side. On the left side, notice above is this vein, which is called the accessory hemiazygos above, and below this is the hemiazygos vein, and notice how both of them cross over, usually at the level of the 8th thoracic, and they join the azygos vein. What I want you to see also is this here is the internal thoracic vein, and this is the musculophrenic vein. I don't think it's been labeled here. Notice this is the musculophrenic vein, and this one will be superior epigastric. So from the lower spaces, the anterior intercostal veins drain into musculophrenic, which drains into internal thoracic. The upper part of, well, let me say that again. The upper anterior intercostal spaces, the veins drain directly into the internal thoracic vein. So whenever you're talking about drainage, you always talk about direct drainage. So if I asked you, where does the vein from the where does the anterior intercostal vein from the 9th space drain? You would say musculophrenic. Where does the anterior intercostal vein from the 5th space drains into internal thoracic? And then internal thoracic goes into, you can see up here, internal thoracic will go all the way up, and it actually drains into subclavian, sometimes into the brachiocephalic. Let's look at the posterior intercostal veins. So here on the right side, notice most of them are joining this azygos vein. A few of them in the posterior intercostal space on the right side are going directly into brachiocephalic. So you can see a few of them going directly into brachiocephalic. On the left side, if you can look at it carefully, they drain from the lower spaces, they are going into the hemiazygos. From the upper spaces, they are going into accessory hemiazygos, and some go directly, which we'll see in another picture, some go directly into the brachiocephalic. I don't need for you to remember exactly which one goes into brachiocephalic and which ones will go into accessory and hemiazygos. So here this gives a better view of this. So you can see azygos on this side, accessory azygos, hemiazygos. Notice most of them posterior intercostal on the right going into azygos, a few going directly into the brachiocephalic. On the left side, notice a few going directly into brachiocephalic. The upper spaces going into accessory, the lower spaces going into hemiazygos, and then this crosses over. So finally all the blood goes into the azygos system, because you want to take it back to the heart, and the superior vena cava and inferior vena cava are what enter the heart. So this is showing you the same thing up here. And right here, since this picture does show it, I also want you to look at this structure called the thoracic duct. We will be doing this later, but just so that you know, notice how this thoracic duct is present initially on the right side, then crosses over on the left, and notice it opens into this vein here, the junction of subclavian and brachiocephalic. We will be doing it again, but when you have images like this, I want you to kind of pay attention to any extra things that we see. Let's look at the nerve supply now of the thoracic wall. So the intercostal spaces are supplied by the intercostal nerves, and the 12th nerve, which is below the 12th rib, is called the subcostal nerve. Subcostal nerve. These intercostal nerves are the ventral rami. This is called ventral primary rami. So these are the ventral rami of the T1 to T11 spinal nerves. So these are the ventral rami. They give off collateral branches, which we will see. Those collateral branches are the ones which supply muscle. All other branches are cutaneous. The third to the sixth are typical intercostal nerves, because if you remember, we said third to sixth spaces were typical. The others are not typical because the first thoracic nerve, the first intercostal nerve, it joins the brachial plexus, so there's no cutaneous branch. The second thoracic intercostal nerve, it has a large lateral cutaneous branch, and we'll see that. And this lateral cutaneous branch goes into the axilla and the medial side of the arm, and it actually connects with another cutaneous nerve, which is called medial cutaneous nerve of the arm. So it connects with another nerve, and this branch is extremely large, and so it goes into the arm. So again, this is a bit irregular, not typical. And T7 onwards, T7 to T11 and the subcostal, they don't remain in the intercostal spaces. Instead, they go down and into the anterior abdominal wall, and they supply the anterior abdominal wall. So they are again not typical. So therefore, third to the sixth are typical. And all the intercostal nerves have sympathetic fibers. We saw earlier, all spinal nerves have sympathetic fibers. Intercostal nerves are nothing but the ventral rami of the T1 to T11 spinal nerves. So they will have sympathetic fibers in them, which supply the erector pylorem muscle, the sweat glands, the blood vessels in the skin, and all of that. So here let's look at an typical intercostal nerve. So here is the spinal nerve which comes out from the spinal cord. It gives off this posterior or dorsal ramus, which goes to the back and supplies the back, gives muscular and cutaneous branches. And then here is the larger ventral ramus. This ventral ramus is the one which we call intercostal nerve. So you can see how all intercostal nerves are branches of ventral primary rami of the T1 to T11. As this nerve lies in the intercostal space, remember it was lying in the costal groove, it gives off a branch here which is known as the collateral branch. This is the one that supplies muscles. And then it travels, gives off a lateral cutaneous branch, which you can see has both anterior and posterior, so that it can supply the skin on the lateral side of the trunk. The nerve continues forwards and then comes up here, where again it divides into medial and lateral cutaneous branches to supply the skin on the front, both medially and lateral. So you can see how many cutaneous branches there are. The collateral, as I said, is the one which supplies the muscles. Now T1, as we said, has no cutaneous branch. It goes to join the brachial plexus, and through the brachial plexus it's represented here. T2, this one, if I was to show you T2, this lateral cutaneous branch is extremely large. It actually goes here and supplies the floor of the axilla and the medial side of the arm up here. So therefore it again is irregular. And then T7 to T12 all go into the abdomen, so they travel down like that, so they don't lie in the typical intercostal spaces. So that's why T3 to T6 we say are typical intercostal nerves. And I also want you to look at this disconnect which we talked of. So if you see above the sternal angle, this area is supplied by the cervical segments of the spinal cord. So this is cervical segments of the spinal cord, and below that is T2. So there's a disconnect there because of this fact that T1 goes into to join up with the brachial plexus. Now pain from the heart, visceral pain from the heart, travels to the upper thoracic and the cervical segments of the spinal cord. So when the brain refers the pain is referred all along the front of the chest wall, front of the sternum. It is referred along the medial side of the arm, and that's because of this intercostobrachial nerve. It may even be referred up to the jaw, and this is because of that common nerve supply. Now, often you might have to do what is called an intercostal block if you're doing minor surgery in the thorax, or there's some painful condition, you need to block the nerves. So the intercostal block is often done near the angle of the rib. So where the rib kind of turns around, there's an angle of the rib up there. And it's not really necessary to anesthetize the collateral branch because it's muscular. All you want to do is you want to anesthetize the cutaneous branches. So you'd like to kind of give the block somewhere there so that the collateral branch escapes. Because sympathetic fibers are carried in these intercostal nerves, you should understand that if any intercostal nerve is damaged, that area, apart from sensory loss, the muscles there will be paralyzed. You would also lose there would be no sweating in that area because the sympathetic supply is gone. So the hair would begin to fall off because sebaceous gland are not secreting, and so no lubrication. And that area would feel warm because sympathetic fibers they constrict the blood vessels of skin. So if the sympathetic fibers are damaged, then the blood vessels are dilated. So the area feels warm and dry to touch because no sweating and the sebaceous glands are not working as well. Lymphatic drainage is pretty simple. If you look at superficial tissues, which is the skin and outer tissues up here, from the superficial tissues, you can see anteriorly they go to this group of lymph nodes, which is called parasternal group of lymph nodes, and from the posterior and a part of this lateral portion they go to the axillary group of lymph nodes. The deeper tissues, which involve the muscle and the endothoracic fascia and so on, anteriorly they go to the parasternal group of lymph nodes, and posteriorly they travel to the intercostal group of lymph nodes. So this is fairly simple, not much explanation needed here. But I do want you to notice where the parasternal, intercostal and axillary group of lymph nodes are present. When we look at the thoracic diaphragm, it's this big sheet of muscle. It's not a muscle of the thoracic wall, but it separates the thoracic from the abdominal cavity. And this is this huge sheet, which I told you in class was like an umbrella. So it goes right from the sternum along the costal cartilage right up to the lumbar vertebrae posteriorly, and all of the fibers traveling from in front, traveling from the side, traveling from posterior, all of them come down. So it's like this huge thing like this. So it forms two domes, a right and a left dome, and all of them insert into a little tendon in the center, which we'll see, which is called the central tendon. Anything to do with the diaphragm, the word phrenic is used. So its blood supply is through musculophrenic, and there are two other blood vessels called superior and inferior phrenic vessels. This stands for vessels, inferior, superior. The nerve supply, the motor nerve supply, that means supplying to the muscle, is through the phrenic nerve, which also carries sensory fibers. And phrenic nerve arises from the neck, from the cervical segments of the spinal cord, and it is cervical 3, 4 and 5. So actually it arises in the neck, the nerve, and travels all the way down to supply the diaphragm. So if this is the diaphragm like this, so this nerve travels all the way down. So any injury up here in the neck can involve the phrenic nerve and paralyze the diaphragm. It is a very powerful inspiratory muscle. It is 75% of inspiration is done by the diaphragm. Its sensory supply is from the lower intercostal nerves. So here when we look at the diaphragm, you can see arising from the posterior aspect, arising from the costal margin. The xiphoid process has been cut, but from here, so all the fibers kind of converge on the central tendon of the diaphragm. And you can see the right dome is higher than the left because of the presence of the liver. We talked about 3 major openings in the diaphragm. These are the levels at which these openings are. And when the diaphragm contracts, the diaphragm actually descends. So from this position, when the diaphragm contracts, it descends, and both domes both parts of the diaphragm are supplied separately by a phrenic nerve of each side. Sometimes one nerve may be cut, a stab wound in the neck may paralyze one nerve, the other side may be functioning. So you get what is known as paradoxical movement. So on the paralyzed side, what happens is when the person inspires, instead of the diaphragm descending, it actually ascends. The reason being, let's say if this side was paralyzed, this side functions, so this descends. So when it descends, it pushes the abdominal contents down below, which further push this one. This is not functioning, so they push this one, so this goes up. So during inspiration, when it should actually descend, the paralyzed side ascends. So that's called a paradoxical movement. We can actually help people if they have an intact phrenic nerve, and as I said, it's responsible for 75% of respiration. We can help people gain use of their diaphragm by doing something like phrenic pacing. Just like you have a cardiac pacemaker, if the pacemaker is gone, phrenic pacing is done when there is an intact phrenic nerve and electrodes are placed and they stimulate the phrenic nerve. So that then goes and stimulates the diaphragm, and the diaphragm can function normally. Let's look at the movements of the thoracic wall. And you want to increase the volume of the thoracic wall in all diameters. That means you want to increase it vertically, you want to increase it transversely, and you want to increase it anteroposteriorly. Vertical diameter is increased when the diaphragm descends. As I said, the diaphragm, when it contracts, the domes descend. So when the domes descend, the vertical diameter will increase. The transverse diameter increases because these obliquely placed ribs move up. So you can see this. This is an obliquely placed rib. When it moves up, it increases the transverse diameter. And this is what is called the bucket handle movement, and it is done by vertebrochondral ribs. That means the first seven, the vertebrochondral, the 8th, 9th, and 10th, and also the vertebrosternal, but the lower vertebrosternal. So both vertebrochondral and the lower vertebrosternal ribs. So this is because, and the reason we say bucket handle, if you take a bucket like this and you put the handle which is lying by the side, and that's how the ribs are. They are lying obliquely like this. So in this oblique fashion, if I take, this is the radius. Now if I raise this and make it straight, can you see how it has increased? So these obliquely placed ribs, when they straighten out, so the ribs are placed obliquely initially like this, but then they straighten out this way. So when they straighten and become more horizontal, the diameter taken on both sides increases, and it's the transverse diameter which happens. Increase in anteroposterior diameter, which is known as the pump handle movement, is mainly by the vertebrosternal ribs. That is the first 7 pairs, because they are attached to the sternum. And here what happens, if you remember, I told you that the ribs increase in size from above downwards, and then they decrease in size. So somewhere between the 7th is around the one which has the greatest curvature. So when the lower rib goes up, it occupies, from an oblique position, it becomes horizontal. It's going to occupy the space which has been vacated by the rib above. But the rib above is shorter than the rib below. So this lower rib doesn't find place. So what it does, in order to find and accommodate itself, it pushes the sternum forwards. So when it pushes the sternum forwards, you can see the anteroposterior diameter will increase. So the lower rib becomes horizontal, occupies the space of the upper rib, which is much shorter than it. Because it's much shorter, to accommodate itself, it has to push the sternum forward, and when it pushes the sternum forward, it increases the anteroposterior diameter. So that is known as the pump handle movement. So that's how the volume of the thoracic cage is increased by these muscles. The intercostals are inspiratory as well as the diaphragm. The diaphragm increases the vertical diameter. The transverse and anteroposterior is done by the intercostal muscles. So this is showing you the same thing. So notice the pump handle, as it goes up, it pushes the sternum forwards. This is bucket handle. So this was the diameter. When it becomes horizontal, this diameter increases. This is something that you need to know, look at. There's not much to say. The muscles of inspiration, the principal muscles of inspiration are the external intercostals and the diaphragm. The accessory muscles of inspiration, ones which come when you need to breathe more deeply and you have, there's troubled breathing, for example, someone has asthma and so on. This is done by a muscle called sternocleidomastoid. We have scalene group of muscle and also the pectoral muscles, the pectoralis major and minor. So these are the muscles which are accessory. Expiration is elastic recoil. So during quiet breathing, no muscle really comes into play. It just comes back to its normal position. But during active expiration, like you're blowing out into something, then the internal intercostals and the abdominal muscles, and there's another muscle on the posterior abdominal wall called the quadratus lumborum, these come into play. So these are muscles of expiration, which we can call accessory muscles of expiration used in active breathing out. As I said, in asthma is when these muscles are usually come into play. Now we look at breast tissue. It is a modified sweat gland, consists of fat and glandular tissue. It lies in the superficial fascia over these muscles, and it is separated by a space from these muscles which is known as the retromammary space, and that actually allows the breast tissue to be moved over these muscles. When the breast is fixed, that's when you begin to suspect that maybe there is some carcinoma and it is spreading. The glandular tissue is divided into smaller segments called lobule, which is drained by a duct through which milk passes, and the duct has a dilated end which is called a sinus. And we'll be looking at these suspensory ligaments called ligaments of Cooper, which attach the breast tissue to the dermis of the skin. During carcinoma, these ligaments get affected, and the dermis is tethered to the gland, and it kind of gives an orange peel-like appearance. So here's, if you look at the whole breast, so fat plus glandular tissue. So notice how it is placed in the superficial fascia lying over muscle. And here are the glands. These are the suspensory ligaments which attach the glandular tissue to the skin on top. This is the space between the breast tissue superficial and the muscles lying posteriorly. Part of the breast tissue goes into deep fascia and goes into the axilla. That part of the breast tissue which goes into the axilla is called the axillary process, or also called the axillary tail or tail of Spence. And during menstruation, this axillary tail is often enlarged. So women might find a lump in their axilla and get worried. But after the cycle is over, that lump disappears and then keeps coming back. So that the appearance and disappearance of a lump will tell you that it's just the axillary tail responding to hormonal changes. What I also want you to pay attention here is look at the blood supply. Blood supply always comes from blood vessels which lie close by. So the anterior intercostal blood vessels coming from the internal thoracic plus the perforating branches of the internal thoracic artery itself will supply this part of the breast. From the axillary artery you will get the lateral thoracic branches coming, and the posterior intercostal arteries also from below will supply the breast tissue. This picture also shows you gives you a good idea of lymphatic drainage. And if I was to divide the breast into 4 quadrants like this, notice from this quadrant up here, the lymphatic drainage is going to the axillary group of lymph nodes. These two quadrants, it goes to the axillary group of lymph nodes. Or maybe I should put this a little bit here. This arrow should have been down here. From the medial quadrants, it goes into the parasternal group of lymph nodes. And from this area, mainly this area, the lymphatic drainage can go into the abdomen. So it goes into the abdomen, into the diaphragmatic group of lymph nodes. And this, when we say inferior, it's usually the lower medial quadrant. This quadrant is the one which goes into the abdomen. So let's look at a few more pictures which show us this. Before we do that, breast implants, when we do that, you can do the breast implant in the retromammary space, which is above the muscle, or a more natural way that they do it, they feel it gives a more natural look, is splitting the muscle, the pectoralis major, and putting the implant between the muscle fibers. The blood supply, as I showed you there, is from the internal thoracic, both its anterior intercostal arteries and those perforating branches. You have, again, then on the lateral side, axillary and also posterior intercostal help to supplement it. 75% of the lymphatic drainage goes to the axillary group of lymph nodes. The medial quadrants also go to the parasternal, and we'll see the inferior quadrant, especially the lower medial, so the lower medial, especially the lower medial inferior quadrant, goes into the abdominal group of lymph nodes. So here is the blood supply. So you can see the internal thoracic through its anterior intercostal and perforating branches, the posterior intercostal and the lateral thoracic artery. And here's the lymphatic drainage. So here, if I was to divide it like this, most of it, 75%, even from here, 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 and here, all go into the axillary group of lymph nodes. These medial, both the upper and lower medial also go to the parasternal, so something from here can actually cross over and go to the other side. And from this lower medial, the lower medial is more prone to going to the diaphragmatic group of lymph nodes. So it passes through the diaphragm, going, through the openings of the superior epigastric and the musculophrenic. So it kind of spreads here. So this lower medial quadrant is kind of most dangerous because it could go across this way, it could come down here. Here from this upper medial can go across here, and of course all of them go to the axillary group of lymph nodes as well. So that finishes this lecture. Please, if you have any questions, you can let me know.